Hi, my name is Tamar Brandler. I am the director of the Division of Cytopathology at Rutgers Robert Wood Johnson Medical School at Robert Wood Johnson Barnabas Health System in New Brunswick, New Jersey. And today I'll be talking about the clinical implications and management of HPV-negative cervical cancers and precancers. The learning objectives for this course include that on completion of this exercise, participants will be able to recognize clinical and demographic features of HPV-negative or HPV-independent HPVI, squamous cell carcinoma, and adenocarcinoma. Distinguish survival characteristics of HPV-independent versus HPV-associated cervical cancers and precancers. Differentiate prognostic features of HPV-independent versus HPV-associated cervical lesions, and identify key management strategies for patients with HPV-independent cervical cancers and precancers. According to the American Cancer Society, cervical cancer is the fourth most common malignancy in women, making up 7% of all cancers in women. 5.5% to 11% are actually HPV-negative cervical cancers, and precancerous lesions are diagnosed more commonly than invasive cervical cancers. The incidence actually differs whether it's increasing or decreasing depending on the age group, increasing by 1.7% per year from 2012 to 2019 in women ages 30 to 44, but has decreased significantly by 11% per year for younger women aged 20 to 24, likely due to the vaccine. The WHO 2020 separates cervical squamous cell carcinomas by HPV-associated versus HPV-independent status. HPV DNA has been found to be detected in virtually 100% of cervical squamous cell carcinomas and precancer lesions like H-cell or CIN2 to 3 lesions. And HPV is detected in about 62 to 85% of cervical adenocarcinomas. So there are cervical adenocarcinomas that are HPV negative or independent, whereas squamous cell carcinomas occurring more rarely to be HPV independent. And the HPV vaccine protects against infection and precancer caused by HPV types that cause 90% of HPV cancers. That brings us to our first case, which is that of a 62-year-old woman who tested negative on the HPV testing, and here's her pap test. So you can see some single cells with higher NC ratios, where you actually see only a thin rim of cytoplasm around some of these cells. They're very hyperchromatic cells. They're in the bottom image. You can see actually there's a cell that has relatively high NC ratio, kind of below the group of neutrophils, kind of in the center, but it still has a fair amount of cytoplasm, whereas in the figure on the top left, most cells, I would say, have still a fair amount of cytoplasm, though some of the cells higher up in the image have a higher NC ratio, and in the middle image and the one on the right, again, you see areas where you have relatively high NC ratios, some higher than others, and some of the nuclei you can see have a little bit of an irregular nuclear border. It's a little bit difficult to make out the chromatin, whether it's coarse or not, due to the hyperchromasia, and this case was diagnosed as ASK-H, or atypical squamous cells cannot rule out a high-grade lesion. I guess the pathologist on the case did not have enough evidence qualitatively or quantitatively to go all the way to H-cell on the material at hand. On follow-up surgical biopsy, this patient was found to have H-cell or CIN2 to 3, and interestingly enough, a positive P16 immunostaining, which was diffuse and strong, and is a surrogate marker for HPV. So HPV testing was initially negative, but then the P16 staining on follow-up was positive in this case. Here you can see an article that was published in Modern Pathology on HPV-negative tumors of the uterine cervix. And on the left, you can see the Kaplan-Meier curves that are illustrating disease-free survival and overall survival based on HPV status. And the broken line is HPV positive and the solid line is HPV negative. And you can see that the HPV negative is much lower across time for both the disease-free survival and the overall survival than the HPV positive cases. Additionally, if you look over to the right at the table 1 from this paper, you can see there's a number of areas that had a statistically significant difference where the p-value is less than 0.05 between the HPV negative and HPV positive cases. So age, for instance, was one, clinical presentation, histologic type, P16 status, positive or negative, tumor size, FIGO stage, and lymph node metastasis all showed statistically significant differences between the two groups. Here's another table from the same study that specifically focused on the squamous cell carcinoma lesions that were HPV negative versus positive, and the statistically significant difference is illustrated with clinical presentation, such as clinical symptoms or abnormal pap smear, P16 staining, which tended to be positive in HPV-associated lesions and positive or negative in the HPV negatives. Tumor size tended to be larger in HPV negative, and FIGO staging tended to present at a higher stage in the HPV negative cases. So in this study, in order to exclude the possibility of false HPV negativity due to viral integration, they actually analyzed the presence of HPV E7 DNA by PCR targeting E7, in addition to the detection of the DNA of the HPV. All cases were negative for E7 DNA, confirming that they were truly HPV negative. However, the study design did not clarify whether the HPV-negative cervical cancers represented the clearance of the HPV in tumors that were initially HPV-associated, or whether they were truly HPV-independent tumors. But either way, these lesions were associated with poorer prognosis, and this was interesting because it could be confusing when you have a case that does present as HPV negative with a PAP that has H-cell or, ASK-H or higher lesion, and then may actually end up having on the surgical follow-up a P16 positive result, and kind of how to make heads or tails of that. Which brings us into our next case, and that is a 27-year-old woman with HPV negative results, and this is her PAP test. You can see on each of these images there are single cells that appear to have very hyperchromatic nuclei with irregular nuclear borders. Some of them have a little bit higher NC ratio, but not high enough all the way to get to an H-cell diagnosis. So this was called ASK-H. The follow-up on this case actually confirmed an H-cell CIN3 diagnosis on the cervical biopsies, and this case, in fact, did turn out to be P16 positive on immunostaining, despite the original HPV negative testing. In order to try and make sense of an HPV negative test followed by a surgical pathology displaying P16 positivity or surrogate marker for HPV, you may want to consider the causes of a false negative HPV test, one of which could be due to the loss of targeted HPV DNA fragments, such as the HPV-L1, which is typically the target of many HPV tests. However, it can be destroyed when viral DNA integrates into host DNA. And because the oncogenes E6 and E7 also may not be expressed during the development of cervical cancer, it's best to target both the E or early genes and the L or the late genes so as not to miss the diagnosis. Another possible reason for a false negative HPV could be low viral load in latent HPV. Also, glandular epithelium often do not support HPV viral infection. Cervical cancer caused by low-risk HPV genotype would additionally cause a false negative because most HPV tests target the high-risk HPV. Low-risk HPV genotypes are seen in 1 to 2% of primary cervical cancers, so they're not that common, but they are possible. Another possible reason for false negatives would be incorrect classification of non-cervical cancer. So you need to be careful to understand whether or not it is a primary cervical cancer or actually direct extension or mets from another location. Another possibility would be incorrect sampling or a pre-analytical, which can cause the false negative HPV results due to sampling a scanty cellular material region from necrotic or inflamed areas, presence of blood or lubricant in the sample, time elapsed between excision and fixation, degradation of viral DNA, RNA, especially in the formalin fixed and paraffin embedded specimens, and samples from older patients, as well as longer storage, can all be factors to consider. Now I'm going to discuss our third case. That's of a 38-year-old woman with an HPV negative co-test. And you can take a look and see that there's actually quite a bit of blood in the background. And then we see our groups of cells that look pretty hyperchromatic, although everything looks kind of dark in the staining here. So I'm not 100% how real is it hyperchromasia versus dark staining versus some degeneration, because we do see it's pretty bloody. But there are some cells that are more concerning. And again, they do look pretty dark, some angulation or irregular nuclear borders. And this case happened to be called low grade with a few cells suggestive of high grade. Now, the PAP for this case may have had artifact on it, or it may have just been sampling, because when the cervical biopsies were performed and the endocervical curetting, low-grade squamous intraepithelial lesion was confirmed, but no high-grade was seen. So again, it could be sampling, or it could just be an artifact of how it looked. But this case turned out to be a low-grade. The fourth case is that of a 22-year-old woman with HPV negative, and this one was called AskH. And you can see there are several cells that have somewhat higher NC ratio with nuclear hyperchromasia. It is a bit hard to make out the chromatin quality, but you can see somewhat irregular nuclear borders. There's still cytoplasm on all of these cells, so that probably explains why the initial diagnosis was AskH, and they could not go all the way to high grade on this PAP. Interestingly enough, on the cervical biopsy, the case was called low-grade squamous intraepithelial lesion, scant evidence, and P16 was considered to be focal patchy positive, which is not entirely clear because there was no high grade noted in the case. But just something to keep in mind, because this was a case that tested HPV negative on the PAP, with the sample that was collected with the PAP, yet there was possible P16 focally. So what would be the management of HPV-independent cervical adenocarcinomas? As we said, squamous cell lesions are very uncommonly HPV-independent. Cervical adenocarcinomas, also not that common. But what would be the management? Well, it's important to consider, as with other tumors, having the multidisciplinary tumor board planning where you can have contributions from all disciplines, and making decisions based on prognostic and predictive factors for the oncologic outcome, quality of life, and morbidity of the patient. Counseling is important in this and all situations, and staging should be performed according to the TNM classification, and clinical staging, FIGO, should be recorded. Diagnostic workup should include pelvic examination and biopsy with or without colposcopy, pelvic MRI to assess pelvic tumor extent. You can do endovaginal or transrectal ultrasound. You can do a cystoscopy or rectoscopy. For biopsy, if urinary bladder or rectum shows suspicious lesions on the MRI or ultrasound. A distant diagnostic workup, according to the ESCO guidelines, includes surgical staging of pelvic lymph nodes to assess the prognosis and guide treatment in earlier stages. And in the T1B2 and higher, or early stage disease with suspicious lymph nodes on imaging, PET-CT or chest abdomen CT is recommended for assessment of nodal and distant disease. In locally advanced cervical cancer, consider para-aortic lymph node dissection for staging. To summarize management, based on the staging, the earlier staging, 1A1, typically you would do a cone to preserve fertility for HPV-associated squamous cell carcinomas or extrafascial hysterectomy. However, for HPV-independent tumors, such as HPV-independent adenocarcinomas, fertility-sparing treatment is not recommended. Surgical margins should always be clear, of course. For the stage 1A to 2A1 lesions, surgery would be the appropriate management, and 1B3 to 4A would have concurrent chemoradiation. Adjuvant treatment after radical hysterectomy, depending on surgical findings and the disease stage. In summary, patients with HPV-independent tumors tend to present at older ages than the HPV-associated tumor counterparts. They're diagnosed due to clinical symptoms, and they're often non-squamous type. P16 is often negative, and they typically present at advanced FIGO stages. They more frequently have lymph node mets and have poorer disease-free survival with increased tumor-associated mortality. False negative HPV testing can be due to lack of expression of either early or late genes, low viral load in latent HPV, low-risk HPV, non-cervical cancers, or sampling or pre-analytical errors. And management is similar to that of HPV-associated tumors, except due to the more aggressive nature of HPV-independent tumors, fertility-sparing treatment is not recommended even at stage 1A1, which would be microinvasive disease. I wanted to thank you all so much for being a part of this presentation today.